Yes, ma'am, please.
Good afternoon, everyone. I am Dr. Ashu Grover. We are starting this webinar in the area of general surgery to tell the participants about the standard treatment workflows which have been developed by ICMR in collaboration with National Health Authority, WR Country Office, India, and the experts drawn throughout the various institutions, colleges, and public healthcare system throughout the country. So these standard treatment workflows, they have been developed keeping in mind that there are a lot of lengthy guidelines or various cumbersome guidelines developed by various organizations and the agencies. So which was felt that some of these guidelines may or may not be well utilized by the physicians who are treating the patients at the public healthcare system in their respective OPDs or the IPDs. And some of the investigations also may or may not be necessary, but still the patients have to go through from that angle. So these standard treatment workflows, as a part of the Government of India initiative, were started in 2018-19, wherein the need was felt, and at that time we had identified certain topics which were of high significance and importance. For example, the cardiology topics like the heart attacks and some of the surgical procedures like cholecystectomy and all that. So a National Health Authority also joined us in this endeavor because they were getting a lot of requests for the reimbursement packages and the procedures for their various set of investigations and the operative procedures. They also needed some clinical guidance. So these standard treatment workflows which have been developed by ICMR, and it is an ongoing process which is being done right now. Though these workflows are the clinical guidance document for the NHA, and as well as primarily these are for the physicians who are either into the public healthcare system or into the private healthcare system. The public healthcare system, as we know the hierarchy, we have the sub-centers, the PHCs, CHCs, health and wellness center, district hospital, sub-district hospital, tertiary care hospitals, medical colleges. So it was felt that all these physicians they have been going through a robust training at the time of their graduation and the post graduation, but once they start practicing, they really need a summary of the workflows of the process or the steps for which they need to take care and examine the patients. So we have taken care of all those factors, that they have to be short, they have to be inclusive of most of the things like clinical features, symptoms, what to do, what not to do, how to refer, what are the set of investigations which are essential, optional, and desirable for that particular condition. Efforts have been taken to put up the images also into the workflows so that the clinicians can easily identify the condition whenever they are sitting into the OPD. So these workflows, we have the third webinar, and we have putting all our efforts to get it and reach it to the end user, who is a physician in this case, and to get it more and more utilized and take the patients and examine the patients using these workflows. So today we are having the standard treatment workflow webinar in the area of general surgery, where we have Dr. Rajdeep Singh as the chairman of the committee, who was part of and instrumental in developing these workflows, along with Dr. Virender, again an eminent surgeon, along with the various experts, which Dr. Rajdeep will tell us about it, who have developed these workflows. And this webinar will be telling us about that what are those conditions in which general surgery STWs have been developed, and what will be the next step. We don't stop here, so these STWs will be on a dynamic process and keep going on. So with this, we start this webinar, and I welcome Chairperson Dr. Rajdeep Singh and his team member, who was instrumental in developing the standard treatment workflows, and the participants who have joined across various colleges, institutions, states, and public healthcare system and the private system to this important webinar. Thank you so much. Now I maybe tell Dr. Lokesh, who is a part of our STW team, to tell us that where are these accessible and how these can be available. Dr. Lokesh.
इसको वो कर दो ना, इसको पूरे पैर से छोटा कर दो, ऐसे Good evening, everyone. Briefly, I will show you how we can access this ST standard treatment workflow. Before going to that this is the structural framework which was followed during the developing the standard treatment workflow. Like we have the advisory committee, we have the different subject-wise specialty, subject-wise or specialty-wise the expert committee, which provide the feedback. Based upon that, ICMR STW team develop the STW. After that, it goes to editorial board. After approving the editorial board, STW is available in the form, book, mobile app, and web portal. So this is the basically the process or standard process which was followed during the STW development. So we are not going to detail on the procedure. And when we say about the expert, so experts for development of these STWs, we can say that across the India, every state participated to develop this this STW. When we talk about the key feature of STW, it is one pager, all-in-one means all. When we take one condition or one disease, so it will provide all from beginning to end, means from symptom to management level. All the aspects it cover in single page. It is also available in mobile application, and it is basically for physician, and it is no legal binding, and also where required for the images, all the information illustrated with form of the pictorial or image based. So far 122 STW has been developed with different specialty like cardiology and etc. So these STW are available in book form in three different volume 1, 2, and 3. And now how we can access this STW? So for accessing this STW, you may require to visit stw.icmr.org.in. When you go stw.icmr.org.in, our website, STW website will be open here. So this is our front page where all the specialty is mentioned here. So if you suppose I want to require to see the general surgery, so when I click on this, I will able to see the general surgery, and then first part is it give the all the STW of general surgery, like one by one. It is available in single PDF. All the STW of general surgery is available in the single PDF. Apart from that, it is also available one by one in single PDF format or condition wise single PDF. So as per your requirement, either you can download single PDF or all exclusive PDF. So these are the STW of under the general surgery. And similarly, we have another thing. we arrange all the STW volume wise also. So in this page, you will able to see the in complete book format. It is available like volume 3. You will able to see the all the STW which are available under the volume 3. Similarly, you can download volume 2, volume 3, volume 1 also. So this page provide all STW in single or volume wise the book format. And apart from that, it is also in this page also it is available in single subject wise also. And this is our announcement section. In future also you will able to see the other STW webinar announcement on this particular page. Next, our mobile STW is also available on the mobile app format. Presently, it is available Android and iOS platform. If you are using Android-based mobile, then you can get from Google Play. If you are using Apple mobile, then it is available on App Store. So these are the QR code. Like how we can access this? Just you require to scan this QR code, open your mobile, and then there is a scan QR code option is available. Just scan it. It will, if it is Android, it will send the Google Play where you will see and download and install it. After installing, it will available on your mobile. Click on that icon. It will open on your mobile and this way. Click enter. All specialty will be displayed on your mobile. Then you may require to select a specific specialty which you want to explore. For example, here we are selecting general surgery. Then again, general surgery, we have the 5 conditions. So all conditions will be listed. Just push it in one condition, then you will able to see on your mobile all the STW on your mobile, and it will look like that. Just you have required to scroll down to see the all the feature of STW. And here zoom facility is also available. There are different algorithms. You can zoom it and you can enlarge on your mobile also. That facility is also available on mobile. Similarly, you can see other specialty also. For example, we here like dermatology. If you want to see the dermatology, I require to click dermatology. It will display again the different STW. So one by one. If there is a picture, so picture will be also appear on your mobile. Okay, thank you.
Thank you, Dr. Lokesh, for telling us participants about how it is accessible in different versions. Can I just request Dr. Sudha? Ma'am, are you there online? Okay, maybe Dr. Sudha, she is at National Health Authority, Ministry of Health and Family Welfare, Government of India. So she just wanted to tell us about that, how the STWs are incorporated into the standard treatment guidelines documents of the reimbursement packages. So, however, they are available on both the websites, in NHA website as well as the WRO office as well. Now we move further to the webinar, the real context of the content what we are going to discuss today about the STWs in general surgery. So Dr. Rajdeep Singh, sir, will you overview about the STWs, how it has been developed and what is utility and who all could be the users for these workflows, sir. Dr. Rajdeep, sir.
Thank you very much, Ashu. And in the outset, let me thank ICMR for starting this big project. Due to COVID, it was a bit delayed, but better late than never. So when we started this project, we thought about 2 things. One, it should be helpful to most people at the primary level, and yes, it should benefit other levels also. And secondly, we wanted it to be representative of most of India, all parts of India. So for that, we started with Dr. V.K. Bansal. He's a professor of surgery at AIIMS. He's a co-chairman of this committee. Dr. Rajiv Sharma and Dr. Sanjay Gupta, professors of surgery at Government Medical College Hospital, Chandigarh, at the north of India. Then we have Dr. Sukumar Mathi, former professor and head of surgery, Medical College, Kolkata, from East India, and Dr. Monty Khajanchi, associate professor of surgery, State GS Medical College and KEM Hospital, Mumbai. And both Anurag Mishra, Professor Anurag Mishra, my colleague, and me, we are both from Maulana Azad Medical College. So we all sat down together, we had a series of meetings, and believe me, in the beginning it appears very simple that making a one-page STW should be very, very simple. In fact, it turned out to be more difficult because we are used to giving everything in detail and discussing. So even though the STWs were prepared by one person, all of us sat together and decided what is important, what is not important, what can be left out, what is something which should definitely be there. And as you know, medicine is not an exact science. There are bound to be variations from one place to the other, from patient to patient, from clinician to clinician, from disease to disease. But there are some things which are always common and we can always talk about those. So after quite some deliberation, we came out with 5 STWs which have been published. We have others also which are in the process. Now, to begin with, I would call upon the members to present their STWs for different conditions, so common conditions which we have picked up. And the beginning, we are talking about gallstones, one of the most common condition, I believe, and the most common surgery performed by general surgeons all over India. And for this, I would invite Dr. Rajiv Sharma, Professor of Surgery at Government Medical College Hospital, Chandigarh, to present the STW.
Thank you, Dr. Rajdeep. Could you please put up the gallstone disease STW on the screen, because I've not prepared a presentation as such.
Yes, so they'll be putting up the STW, sir.
Yeah, so I can talk about this. So at the outset, I'd like to thank ICMR and Dr. Rajdeep for giving me this opportunity to be part of this great exercise. Gallstone being a very common disease in our country, and almost say about 4 to 11% of people are affected by the gallstone disease. Luckily, only 20% of them are symptomatic, and so gallstones per se may give rise to different symptoms. As you can see there on the right left hand side of the screen, the common symptoms the patient may have, and the most common one is the pain. And at this stage, we really need to find out whether it's a biliary colic or a cholecystitis. So biliary colic is when the gallstone gets stuck and the gallbladder is trying to push it out. So pain would be slowly progressive, constant pain in the right upper quadrant or the epigastrium. But if this pain is for more than 24 hours and it is associated with other symptoms of inflammation like fever or nausea, vomiting, dyspepsia, then we think of the chronic or the acute cholecystitis. The other symptoms these patients may have is they may have dyspepsia, they could have flatulence, they could have intolerance to food. Usually it is to the fatty meals. And if the stone gets impacted at the Hartmann's pouch and it's pushing the common bile duct, patient may have jaundice, or the stone slipping into the common bile duct, and patient may also have jaundice, and it could be a problematic situation. And also patient may have cholangitis. So as such, the gallstones patient may be either purely asymptomatic, doesn't have any stones, and most of the time these stones are being detected when patients have undergone ultrasound for some other cause. So practically every patient, everybody for some or the other disease will undergo ultrasound, and they'll find out that they have the gallstones, and they suddenly become very panicky. But these are the asymptomatic patients. Out of them, about 20% would be symptomatic, and because of these gallstones, there may be certain complications. They may have acute cholecystitis, where the patient has pain, or it's a biliary colic, again, depending. If there is a stone which gets impacted at the neck of the gallbladder, so what will happen that a lot of mucus will be collected inside the gallbladder, and gallbladder get distended, and we call this condition as empyema. This may get infected. The patient may have, it would be a mucocele, and the patient, if this get infected and the pus is collected, then may have empyema. Then patient may also have gangrene or the perforation of the gallbladder. There could be biliary obstruction when the stone gets into the common bile duct. But the most serious complication which may have is the acute pancreatitis, when the gallstone gets stuck at the lower end of the CBD and there is a pancreatitis. This is a serious condition. So once the patient comes to us in the OPD or in the hospital with the ultrasound report of having gallstone, or with either of these symptoms, then we must decide whether this patient needs to be operated or can be treated conservatively or needs a counseling. So if patient has got symptoms, then we have to really act, because we need to operate and do a cholecystectomy. And the various investigation we must do in these patients are, we must do the routine hemogram, renal function tests, electrolytes. Because this surgery, cholecystectomy, has to be primarily done under general anesthesia, so patient should also undergo the chest X-ray, ECG to rule out any cardiac symptoms or to differentiate from the cardiac pain. Liver function tests are important because primarily we'll be dealing with the hepatobiliary system. So we must have the LFTs, where we look for serum bilirubin, SGOT-PT. Especially we look for the serum alkaline phosphatase. If there is any signs and symptoms of the obstruction of the bile is there. And of course, to rule out the pancreatitis, we must have the amylase and lipase. And other investigation are the ultrasound, because this is the one which is going to give us information about the status of the gallbladder, whether there are stones are there or not. We see the posterior acoustic shadows. We want to see what is the status of the CBD, though ultrasound is not a very good investigation for assessing the CBD, but still it will give some information. And we want to know what is the status of intrahepatic biliary radicals. At the same time, the ultrasound will also tell us whether there is an inflammation of the gallbladder, because this is going to decide whether it's going to be a simple surgery or it would be a difficult surgery. So the patient has to be counseled, and the surgeon has to be prepared for the difficult surgery for that matter. Special investigation, if I have to talk about the MRCP or ERCP for that matter, should be done if there is some indication of jaundice, or the patient has got a high ALP, CBD is dilated on ultrasound, or we have a suspected stones either in the CBD, or there is a large stone impacted in the Hartmann pouch pressing on the CBD, and this condition we call it the Merizes syndrome. So all this we need to identify before the surgery, and we can go ahead with the ERCP. Now, once the patient is to be decided for the surgery, there are certain comorbidities are also there, which needs to be taken into consideration, because patient may be diabetic, patient may have old patient may have some cardiac involvements. So for them, we need to do all this sugar profile, glycosylated hemoglobin, cardiac patient. In some cases, we might need echocardiogram for these patients. Patients who have got chest complications, we need to do pulmonary function tests, because these patients are going to be taken up under general anesthesia. So the good chest compliance is very necessary. If patients got obstructive jaundice or some other problems, then their coagulogram may be deranged. So we need to check them so that we can correct them before the surgery. And some patients, we need to do the thyroid function test. So once we have prepared these patients for the surgery after doing all those investigations, so what are the algorithm for the management? For the asymptomatic gallstone patients, we have to tell them that, yes, it's not an emergency. Patient doesn't need a surgery immediately, but eventually there may be a problem. So we have to counsel them that either they want to go for a elective cholecystectomy or they want to wait for it. So the indications for elective. However, in the asymptomatic patients also, we have certain conditions where we must counsel the patient for elective cholecystectomy. And this is if the patient's got a GB polyp. If the polyps are smaller in size, we can ask the patient to be put on surveillance. Than 1 centimeter, then we must go for cholecystectomy because the chances of malignancies are higher. Then we have a porcelain gallbladder. We have a large stone more than 3 centimeters. The larger the size of the stone, they have more relation with the malignancies. Multiple small stones may likely to slip into the common bile duct and cause obstructive jaundice. In pediatric age group, if the gallstone disease is there, then there has to be some hemolytic disorder. So these are the patients they must be counseled for this surgery. But other patients, unless they have symptoms, depending on the various symptoms, I think I will not go into the details because this algorithm itself is a very well explanatory, whether you want to go for a conservative management or you want to go for a operative management. So in either case, either the patient goes for a conservative, or in certain situation when suppose the patient's got acute cholecystitis, and if patient doesn't report well in time, or there is a delay in presenting to the hospital more than 72 hours, then we can delay the procedure for 6 weeks and can go for interval cholecystectomy. So I think this algorithm will give us quite good information about that. In non-resolving patients, the patient we are not fit for definite procedures, then we can go for cholecystostomy, where either we go for open cholecystectomy, but cystostomy. But in today's time, when we have a good ultrasound or imaging guidance available, so percutaneous cholecystostomy can be done and the crisis can be tied over. And once the patient settles down, we can go for a definitive cholecystectomy. Pancreatitis, depending whether the symptoms are mild or severe. In the mild, we can, mild pancreatitis, we can keep the patient in the hospital, and the same hospital admission, we can go for cholecystectomy. But in severe pancreatitis, we must treat the pancreatitis first, wait for 6 weeks, and then we can go for cholecystectomy after 6 weeks. In acute cholecystitis, again, within 72 hours, we can attempt laparoscopic or open cholecystectomy. But after that, more than 72 hours presentation to the hospital, we must settle down the patient by giving IV fluids, antibiotics, rest to the bowel, and painkillers. And once the patient settles down, we go for elective cholecystectomy after 6 weeks. So this is what the algorithm would be there. And one thing which we like to tell all our physician surgeons, that laparoscopic cholecystectomy is the gold standard, but in case there is any difficulty, we should not hesitate to call for help, or we can always have a high threshold for converting, because thinking that we can complete the procedure by doing a laparoscopic cholecystectomy only can sometimes be difficult for us and create complications while doing this procedure. So I think that summarizes all for the gallstone disease. Any more explanation and questions, I would be very happy to answer.
So we'll probably take the questions at the end.
Yeah,
Okay.
thank you, Dr. Rajiv. And just before the next presentation starts and Dr. Rajdeep invites, I may just mention over here that there may be certain queries about various aspects of the how to access these STWs, or maybe topic related as well, the gallstone or common bile duct stone, or whatever topic we have. So please, dear participants, put your queries into the chat box. We will keep noting those queries into the chat box. And at the end of this webinar, when we are done with all the 5 STWs, we will unmute everyone and we will allow everyone to raise the hands and put up the questions. So Dr. Rajdeep sir, we will take all the questions at the end of that, and kindly make the experts available at the question answer session, sir. So we take up the next, Dr. Rajdeep sir.
Yes, thank you, Dr. Grover. Now, so if I just to summarize this straight away, it is just that most gallstones would require surgery. If there is a problem like jaundice, they should probably be referred because they need further investigations. And Many post-op patients also come. Any patient who is not well 24 hours after the lap poly, we should definitely investigate that something is probably wrong. Is Dr. Bansal here? I don't know if he's joined in. Dr. Bansal, have you joined in? I can't see you here in the list. Yeah, sir. The lower one. So Dr. Bansal is professor of surgery at AIIMS. He's a very prolific person, lot of papers, and he's very active. He was in fact the first one who submitted the STWs and reviewed them. So he'll be talking about CBD stones, a very important topic. Welcome, sir.
Thank you, Rajdeep. I think I would like to thank ICMR, Professor Balram Bhargav and Professor V.K. Pal for actually including me in this group for the STWs, and Dr. Ashu Grover for the coordination and all the efforts in continuing this group and coming out with this beautiful standard treatment workflow, or STW as you call it in short. Am I audible to everybody?
Yes, sir. Very good.
Okay. So I think as I scan through the list of people who are online, majority of the people are, majority of the participants are surgeons. It seems to me from the list of people who are online. So I'll not explain what this STW about the common bile duct stones is. I think all of the participants are well aware of the management of common bile duct stones, but I'll just take 2-3 minutes to dwell upon that why these standard treatment workflows were made and what was the purpose of ICMR behind these standard treatment workflows. Basically, I think these standard treatment workflows are not for people working in peripheral, in tertiary care institutes or even in the medical colleges. Basically, these STWs are meant for actually the physicians and surgeons working in smaller setups in smaller hospitals, and basically for the management in emergencies, and to some extent for the medical colleges and bigger hospitals, say district hospitals like the civil hospitals, to make the treatment standardized across all the country and to be a standard of care for the management of these common conditions. And as Dr. Ashu also said in the beginning, I think these are important guidelines on which the Ayushman Bharat schemes and other government schemes, the reimbursement and the other things are based on basically. So if in the STW it is mentioned that in a patient of gallstone disease, a MRCP may be required in certain circumstances. So the physician who is ordering that MRCP in a patient of gallstone disease can justify his action based on this STW. This can be quoted as a standard document. And as Rajdeep said that although these were made individually by a group of people among us the general surgery group, but then these were deliberated upon by everybody in that group, and generally the agreed on things were added on after I think 4 or 5 revisions of these STWs, and then the ICMR group finally came up with this artwork and other things, and they made it a standard as per the other guidelines, other STWs also. So as far as the common bile duct stones are concerned, all of us know that the presentation, can you go up a little bit? Yeah, the presentation we all know. So we tried to include actually things which the person in the field may or may not know. It is not for surgeons actually. A surgeon will know that as common bile duct stone patients can present with jaundice, acute cholangitis, biliary pancreatitis, or even asymptomatic with gallstone. But these guidelines, these STWs are basically made for people in the field who may or may not be tackling the common bile duct stones very commonly, and it is for those people that we devise these guidelines. And sometimes in such not clear situations, we can have a deranged left teeth. Then also CBD stones can be a possibility. And then coming on to the workup of a patient with suspected CBD stones, I think ultrasound is the primary investigation as the first choice of investigation. And as a surgeon, I would say that if the patient presents with jaundice or if the patient presents with cholangitis, I would prefer to get a MRCP before even endoscopic ultrasound or a ERCP, because the MRCP is diagnostic, whereas the diagnostic and non-invasive investigation, whereas the ERCP is an invasive investigation, which has got a complication rate of its own. So ERCP is not recommended for the diagnosis of CBD stones, but yes, as a therapeutic procedure, if you are doing a ERCP, then yes, then it is definitely a good option for patients with CBD stones. And then the normal routine investigations we all know, which are required in patients with gallstones or CBD stones, as Rajiv already mentioned. Next one. So then we discussed about the management option. That there can be actually two types of patients. Some patients who have CBD stones with gallstone, and some patients may be detected to have CBD stones post-cholecystectomy. So I think the literature is very clear that for post-cholecystectomy CBD stones, ERCP is the best line of management. But if the ERCP fails, then obviously the surgical management is the best line of management. For patients with gallstones and CBD stones, I think now the literature is very clear that if the CBD diameter is more than 10 millimeters, then a single stage procedure of a laparoscopic or a open cholecystectomy and a CBD exploration is the best procedure. But if the diameter of the CBD is less than 10 millimeters, actually there is a discrepancy here, Dr. Ashu. I think we need to correct it. This is not the stone size. This is the CBD diameter actually, which should be there. I'm really sorry if somehow got missed in the final proofreading, but this needs to be the diameter of the CBD. So if the CBD diameter is less than 10 millimeters, then ERCP first and then a cholecystectomy. But then there are certain indications in patients with the CBD stones. If the patient presents with cholangitis, or then ERCP is a better choice rather than single stage procedure. Then endoscopic stenting is a feasible option in these patients. Then we discussed about the surgical options also a little bit. Just to complete the STW for people who are doing laparoscopic CBD exploration or open CBD exploration. So now the data is very clear that a CBD closure without a stent, without a T-tube is the accepted method of treatment. Next, please. Next. And in only very few indications, you may require a placement of the T-tube. And we as surgeons, we all know that may be required in these circumstances where the CBD is more than 2 millimeter dilated or 2 centimeters dilated, or there is an ampullary stricture, or there are multiple stones with hepatolithiasis, or there are recurrent stones. So I think this basically sums up the management of CBD stones. So with the idea that somebody in the field can guide a patient, can manage the patient properly, and can tell the patient that, okay, so you have gallstones, you have CBD stones. So that person in the field can also guide a patient that, okay, you need a single stage operation, so you can go to this center and get your surgery done. See, referral is also very important in all these things, because the patient does not know that where he should go to for a particular type of a treatment. So in a particular area, the person knows that this center will be doing these kind of things, so that patient can be referred to that point of that kind of a setup. I think that was the basic purpose of devising these STWs. And I think what I see in the audience with what is logged on, I think I would request all of them to download these STWs and maybe send it to their areas of influence, to their PG students, and also that it can be circulated widely in the field areas. for which purpose actually these STWs were meant. Thank you so much.
Thank you very much, sir. Very well summarized. So next we have a very common topic of appendicitis, which will be taken up by Dr. Kumar. He's a professor and former head of surgery at Medical College, Kolkata.
Thank you, Professor Rajdeep. Thank you, ICMR and Dr. Anurag Mishra too, for including me in this very important aspect of ICMR on standard treatment workflow. And the subject of appendicitis is so common, and the surgical practice of the management of appendicitis is so standardized that it is practiced throughout the country, from the extreme remote places in the rural areas to the metropolis, by the general physicians, the surgeons, all. So the treatment is standardized. But by this webinar, I want to discuss, to highlight certain important aspects in the standard treatment protocol, which is in this workflow chart, and also some of them may be discussed further in the presence of very learned surgeons who are present also in the audience. They can suggest their points which can be added to this workflow, and I think Professor Rajdeep Singh will also include those things if any suggestion come from the audience. First, we must say that the appendicitis present mainly in 3 different ways. One is acute appendicitis, another is appendicular mass, which may be a lump without any abscess, another may be an abscess, and the third presentation is the recurrent appendicitis. The presentation of acute appendicitis, particularly in the early stage, is so simple that clinical diagnosis by the physical examination is almost never an error, particularly if it is associated with the Murphy's sign. And in Murphy's sign, we must remember that pain always precedes vomiting. Pain, vomiting, temperature always come in sequence. And temperature is not an early symptom. If there is the symptom of pain associated with pyrexia or chill and rigor, we should think something else. It may not be appendicitis. Mainly, we should think in favor of urinary tract infection. Another important clinical finding is the cough sign, which may not be present in very chronic cases or recurrent cases, but any early acute appendicitis, which is at the stage of resolution, the cough sign is an important feature where when you press at the right iliac fossa and ask the patient to cough, the patient will express pain. And diagnosis, ultrasonography in acute appendicitis may be helpful, but emphasis on the clinical examination should be more than on the investigation. But if you remember to differentiate from urinary tract infection, simple urine examination, routine examination, and the blood examination, the full blood count. Next, please roll on the slide. The full blood, complete blood count is very important. Plain X-ray is sometimes advised when the patient present late, when there is perforation, to exclude the free gas under diaphragm, to differentiate it from gastrointestinal perforation, particularly the duodenal perforation. And if ultrasound fails to detect a urinary calculus, then this plain X-ray may be complementary or supplementary to the ultrasound finding. CT scan is not usually needed for the most of the cases of acute appendicitis. We should remember that the complications are more common in certain situations at the extremes of age, when the patient is immunosuppressed, in diabetes mellitus. So in those cases, we should never make any delay in the diagnosis, and the treatment of acute appendicitis should be contemplated as early as possible. And the appendicectomy is the standard treatment for acute appendicitis, until and unless in special situation, when the patient is on travel on the ship, and in those cases, it may not be possible. But non-operative treatment of acute appendicitis is another concept which is emerging. We have not included that in this flowchart, but we should remember the standard treatment protocol for acute appendicitis should be the surgical treatment by appendicectomy. It may be either open surgery or by laparoscopic surgery. In metropolis and in subdivision level even, it is possible that laparoscopic appendicectomy may be offered to the patient, because that is gradually becoming the gold standard in the management of recurrent appendicitis and acute appendicitis. But in case of appendicular lump, the treatment by laparoscopic surgery is may be very difficult, and until and unless the surgeon is very experienced and facilities are available in the advanced center, it should not be taken as the primary procedure. When the acute appendicitis patient present late, suppose beyond 72 hours, and if no mass is palpable, we can go for appendicectomy. But if mass is palpable, we should think in two ways. We can go on for conservative management, that is the Osner regimen. If the patient improves, the conservative treatment will continue. And if the patient deteriorates by certain development of certain symptoms and signs, we should go for exploration. Or by investigation, if it shows there is a localized collection of pus, that pus may be drained with the help of USG by aspiration. With aspiration, the patient will improve, and later we can place the patient for appendicectomy if the patient improves with aspiration only. And during osteoarthritis regime, that the standard remembrance, we should always remember, that is no purgative and no enema. And in case of recurrent appendicitis, please please scroll the chart. In case of recurrent appendicitis, this is another area where the diagnosis is sometimes very difficult. Diagnosis is very difficult in the presence of mass. We should differentiate the lump, whether it is due to tuberculosis, whether it is due to the malignancy, because in those cases, in the presence of lump and malignancy, it will take long time to resolve. Standard routinely, usually in 3 weeks, the lump disappears, 3 to 4 weeks. But if it takes more than 6 weeks, we should think that something wrong is there. There may be associated malignancy in cecum or not. Similarly, in case of recurrent appendicitis, only the clinical diagnosis may be insufficient. In that case, we may need the help of ultrasound, in some cases CT scan, and even in some cases the barium follow-through X-ray. And that will help in the diagnosis. Another thing I must emphasize at the end, when it is a case of appendicular lump or appendicular abscess, if the surgery is decided, it should be always by an experienced surgeon, and it should be always at a higher center. Other point I like to highlight, that is interval appendicectomy. Interval appendicectomy is not mandatory for all the cases for the appendicular lump. If the patient have the persistent symptom in the form of dyspepsia or chronic pain in the right iliac fossa, in that case, we should think for interval appendicectomy. But if the patient has no symptom following the primary treatment of appendicular lump or abscess, we may not go for interval appendicectomy. Another point I like to say about the laparoscopic surgery, laparoscopic appendicectomy with pregnancy. Pregnancy is not a contraindication for laparoscopic appendicectomy. With this, I conclude, and if there is question in the chat box, I will like to discuss. Thank you so much, sir.
Thank you, sir. Thank you very much. You took us through the entire gamut, right from the presentation, investigations, how to manage, and special situations also. Thank you very much, sir. And just for a note for the audience, entire audience, wherever it is written, keep a high threshold for invasive procedures. It's given at the bottom of all the STWs. That does not refer to surgery. Yes, the surgical procedure has to be done. It's an invasive procedure. That actually refers to invasive investigations. So a high threshold is to be kept for that. For the next presentation, I invite Dr. Monty Khajanchi. He's at KEM Hospital, Mumbai, and he'll be talking about diabetic foot. Dr. Monty had prepared diabetic foot, but here I would like to mention that Dr. Novojit Roy was also very much part of this, but later on he had to move out to his due to other commitments. So Dr. Monte, over to you, please.
Thank you. I hope I'm audible, Dr. Rajdeep. Thank you
Yes,
for
Dr.
this
Kumar.
invite. Yeah. And thank you, ICMR, Ministry of Health. I think the standard treatment workflows are very important documents because till now, it's as we all know, medicine is pretty gray, and we don't have any guidelines, Indian guidelines to follow or Indian PAT protocols to follow. And the Ministry of Health taking this initiative of making, at least starting with these kind of basics or the common conditions in general surgery and in other specialties. I think this is a step towards improvement in the quality of care, right from the person. These were developed for people working at not a tertiary care center or secondary care, but a primary care center or a district hospital. They're far away from the resources available in these hospitals. And so what they can do there and what they need to refer to a tertiary or a secondary, so that there is not too much burden on the tertiary care, and they do not fall into a medical legal holding or mismanage the patient. So I think these are important documents. We should have more of these on various topics like emergency care for for a lower GI bleed or an upper GI bleed, DVT management, pancreatitis. There are so many topics in surgery, I'm sure in other specialties also, that we see, at least starting with the emergency and then going on to the elective, I would suggest. But these are much needed, and we've taken the first step. So we had the thing to develop on diabetic foot, standard treatment workflows on diabetic foot. And what we tried to cover here is not too much into diabetic foot because it's a complex management as we go deeper and deeper into diabetic foot, but at least tell that what are the important aspects. How do you kind of see a person with diabetes who's not got an ulcer, and people who've come with an ulcer or other problems of the feet and have got underlying diabetes. So I think in the evaluation of the patient, you look at the systemic or the whole patient as a whole, look for the vital signs, because that tells you a lot about if the patient has come with an ulcer or a wound or some kind of a discharge or a swelling in the lower limb. Then in the evaluation, the vital signs tell you whether this thing has got generalized or systemic, or it is still local to the foot. So that gives you a fair idea by just monitoring the vitals. Yes, we need to understand what kind of sugar control the patient has got, whether he's a new diabetic or whether he's well controlled, and doing HbA1c and basic investigations will guide us. We do need to look at the local examination to see how much is the foot infection, if it is present, or it's non-infected foot, or there are other problems associated with the foot, like arterial disease or neuropathic foot or deformities which require a higher center referral. So this whole division of local examination into an ulcer, whether it's infected or not an infected ulcer, whether there's an underlying osteomyelitis or no, and when one has to refer these patients to a higher center, has been kind of laid down here. We will move on. We've just given a few of the predisposing factors for the diabetic foot ulcers. What are the general conditions that do patients develop a diabetic foot ulcer, and what are the local conditions why they develop these ulcers? Moving ahead, as I said, diabetic foot leads. There are 62 million diabetics in India, and 25% of them develop a diabetic foot ulcer, with 50% of them getting an infection in these ulcers, and around 20% of them have to undergo an amputation, which is more than 1 million of patients going an amputation each year, and that's a huge number. And they range from a minor amputation to a major amputation where they lose the whole limb. So the best way is to do a risk assessment of and follow these patients up and see which categories they come into. And if they are into a higher category, they should be followed, even if they don't have an ulcer. These are all for prophylaxis or to a prevention of an ulcer. Even if they don't have an ulcer, one should kind of see them more frequently, and to see if they don't develop an ulcer, if their foot condition is okay, and refer them if they have any symptoms or if they have any signs suggestive of a foot at risk. So how do you do a basic dressings? Most of the diabetic foot require a very, very basic dressing. There are a lot of advanced dressings available, which are good. But I think if you can do a clean, basic dressing, a sterile dressing, that's the most important part. There are a lot of dressings which are available. A lot of machines are available to do these dressings. Hyperbaric oxygen, antimicrobial dressing, stem cell therapy. But there is not enough literature to suggest that one should go for it. Again, what kind of infection one falls into in a diabetic foot and what kind of referral he needs is being described, ranging from non-infected to mild infection, which can be managed at the primary or the district hospital. Anything which is moderate or deeper infection or severe infection causing systemic signs would require a referral to a higher center. Along with the diabetic foot, when they come for diabetes and other checkup of the foot, one has to look at if they are developing pons, velocity, web space infections, if they have ingrown toenails, because these all can be the starting points of a deeper infection, and one has to kind of break the cycle here to prevent a severe foot infection. Some patient education material is also say what should you do, what should you don't for a diabetic foot has been described. So in all, a very comprehensive kind of document which one can put into their PHCs on the wall to kind of quickly assess a diabetic foot and when do they need to refer these patients. And one of the things which I keep saying in diabetic foot is the diabetic foot ulcer is just the tip of the iceberg. So don't forget to make sure that you look deeper or do certain tests to find out what is the underlying bone condition, what is the neuropathy, what is the peripheral artery disease status of these patients, because without that, the foot examination is incomplete. So, yeah, thank you, Dr. Rajdeep and Dr. Bansal for inviting me.
Thank you, Monty. Thank you. And this is one of the STWs which has a cross-specialty application. Diabetics are seen by practically everybody, and physicians would be seeing these patients every day. Like you said, 1/4 of them would have diabetic foot ulcers. If they're picked up early, they can be preserved. And the only problem is sometimes they're not picked up, they present late because they have no pain at all. And by the time they present, it's too late and they end up with an amputation, which we want to avoid, obviously. So for the last presentation on ventral hernia, I invite Dr. Anurag Mishra, my friend and colleague at Maulana Azad Medical College. He's a professor there. Dr. Anurag, please.
Thank you, Dr. Rajdeep. I, at the outset, would thank ICMR, Government of India, and MHA to taking this initiative of creating this STWs. I think all my colleagues have said enough about it, but I reciprocate and I echo their feelings. It was much needed in a country like India, where a lot of heterogeneity is there. Some kind of standardization is needed. And I'm really thankful to the authorities to taking this initiative and making us part of it. Coming to ventral hernias, if you look, it's a very, not very crowded page. Kind of, when we were deciding on ventral hernias, we thought that if we go into too much of detail, it will cause a lot of confusion. So we kept it very simple, very basic. And these define the minimum criteria. So we have not gone into complex investigations, very hi-fi investigations, so that people and whatever center, surgical specialty center or surgical center is there, they're able to manage at least 60 to 70% of these cases. So that was the kind of document we were creating. And also we tried to highlight the red flags or pointers when they require a consultation with a higher center or a specialist center, or they need to be referred. So we thought that that would be a good way to put the first version of the guidelines. So if you see in the initial part, we define the defining criteria of hernia, which is clinical. So just a swelling and with a cuff impulse, which reduces on lying down. It's a typical description of a ventral hernia. And the first question or first decider is to decide whether it's a emergency or it is a elective routine procedure. So if there is a severe pain, generalized colicky pain, or there is a sign of obstruction, intestinal obstruction or strangulation, it is a surgical emergency and has to be managed in surgical emergency. So depending on the capacity of the center, it can be managed there, or it can be referred to a place where emergency care can be provided. If there is no such severe or red flag signs, then the second decider is whether it's an incisional hernia or it's a primary ventral hernia. So that will depend on whether there was a history of any surgery at the previous site, at the same site. And if it is yes, it comes in the definition of incisional hernia. If it is not, then it is a primary ventral hernia. So investigation, as it is pointed in the STW, that it is needed only when there is any doubt in diagnosis. In most of the cases, diagnosis can be established just on a clinical examination, so it might not be needed. However, in incisional hernias, generally CT scan or imaging is advised because sometimes the number of defects and accurate size may not be clinically perceivable. So in that case, we have advised CT scan or ultrasound in those cases. Management criteria is kind of very clear, and in bottom we have given an elaborate table based on the size and the site also, and those tips are given. So broadly, the thing is the use of mesh, because most of the centers they decide based whether availability of mesh is there or not. So if it is more than 2 centimeters, we advise mesh. If it is less than 2 centimeters in primary hernias, mesh may not be needed. In incisional hernia, in all cases, mesh will be used. The red flag signs are there. If it's a large hernia, which may require a more sophisticated operation, which is component separation, parastomal hernias, more comorbidities. If there is a loss of domain, if there is the main abdominal cavity is small as compared to the hernia content, then it can be a complex issue, which may not be, the center may not be able to handle. So it can be referred to higher center. If there is non-availability of mesh and the hernia is more than 2 centimeters size. So all these signs were, all these red flags were described. Post-op complication list was there mainly to explain to the patient in pre-op period that these can be the complications which they might have. The kind of the same clinical evaluation which is there above, it is given in more detail. And this is the table I was talking about, the choice of repair table. So where according to the size, can you scroll down further? Yeah. Full down. Yeah, perfect. Thank you. So more than 2 to 4 to 8 centimeters, and various procedures are prescribed. We have not tried to go into the details of the surgery, as obviously, because if there's a surgical center, they would be doing these procedures. There are some specific sites like subxiphoids, suprapubic, and parastomal, and we have kind of advised the one standard procedure which can be followed. So this is about ventral hernia. If there's any question, I can take it, or back to Dr. Rajdeep.
Thank you, Anurag. Thank you very much. And these were the 5 STWs which we have prepared already. They are available on the website, on the mobile app, as well as in a book form. So I presume that the app would be most convenient for everybody. Like Dr. Lokesh said, if you go to the ICMR website, you may have to go through a number of links to reach the STWs. It's better you go straight to the subdomain of stw.icmr.org.in, and that opens the STW straight away. So that happened with me actually. I was searching for it on the ICMR website and that took some time. I have got the app on my phone, and it's generally thought that it's for a particular specialty. Yes, it will definitely be useful for the physicians. But let me tell you, when I saw a patient with drug reactions, I thought maybe, is it a drug reaction or not? I refer to the STW for the drug reactions which are available. At least as a surgeon, I knew whether it is likely to be a drug reaction and what is to be done. So it is not only for the primary care physicians, it is applicable cross specialties also to a number of people. These STWs will always be work in evolution. Dr. Bansal pointed out an error. I picked up a couple of spelling mistakes in it. We will be correcting those. But the entire audience, please do let us know anything you do not agree with, anything you feel should be included, or there are any other errors in the presentation or in the designing of these STWs. Please do let us know, and we will correct it in the next volume, the next edition of this volume. you can email it to Dr. Ashu Grover, the ICMR team, or to me or any member of the STW. So, yes, like Dr. Bansal mentioned, please do disseminate these STWs to your residents, to your MBBS students, because after that, when they go into practice, they are definitely going to need it. At the MBBS level, most students would think that this is not something which is going to get them marks in the exam. But believe me, later on, they are definitely going to require it.
Thank you. Dr. Rajdeep. Are there any queries in the chat box, Dr. Soumya, or there are any hands? So you can unmute or allow the participants to raise the hands. So if there are any queries, please raise your hands. We can go one by one.
Was the certificate question?
So Professor Anurag has mentioned his email ID in the chat box. So if there are any specific queries related to ventral hernia or whosoever, so you can. So we have Dr. Sudha Chandrasekhar also, who has joined with us. So just 1 minute, ma'am, can you tell us about these applicability? Dr. Sudha?
Thank you, Dr. Ashu. I think along with the STW expert team, we have tried to make sure that it is as simple as possible in terms of the implementation also, because we have integrated within, at least for the PMJY, as a first use case scenario, where all our hospitals are mandated to follow these STGs, and the processing and the claim payments are also linked to ensuring that the documentation and the relevant clinical scenarios in terms of the treatment are followed before the claims are settled. So these are also audited at the as a part of the medical audit, so that wherever the cases in which don't follow, we also try to give feedback to the hospitals and ask justification, so that in case there is variation because of the patient characteristics, we also want to understand and try to make the changes for in future. For the public hospitals, definitely we have tried to be more considerate, because in terms of the huge workload that they have and the kind of variety of cases that they see, but it's more strictly enforced for the private hospitals. So we are very happy that we are associated with the ICMR team, and we continue to prepare these STGs as and when we develop the new packages. So that has made sure that the effort is dynamic, and we want to make sure disseminated as much as possible among all our hospitals and the clinicians, because they are the key people who will ensure adherence to these STGs for the scheme as well as in the general practice. So thanks to the ICMR team for this opportunity, and we'll connect and continue to work with your team in the future also. Thank you, Ashu.
Thank you, Dr. Sudha. Despite of you are traveling somewhere, so you took out some time to tell our participants its significance and importance to all. So we have Dr. Bansal, we have Dr. Rajiv and Rajdeep's, everyone's email ID on the chat box. And Dr. Lokesh already told the ICMR or STW website, so where you can go through and see that how these STWs are available. So I would like to, in the end, with this, we come to the end of the webinar. But before we end up, my sincere and humble request to all the participants who have joined here, you must have seen that these are such a simple workflow which have been prepared. These have been, taken up with the experiences of all the experts who have developed it. They have taken up the hard work to put it as simple as possible, so that they are good to understand, and even the medical officer in any of the facility is made aware of the treatment procedures what he should follow. So once in all, so on behalf of DG ICMR, I thank all the participants and the experts and the chairpersons. Thank you.